So we have a 45-year-old lady with no family history, no comorbidities, and she presents to you with the history of early satiety, abdominal distension, abdominal pain. Investigation showed the CT scan shows gross ascites or mental disease, peritoneal disease. CA 125 is 2000. How would you approach this case, Dr. Shrikant?
We would like to go ahead with the ascitic fluid cytology cell block with all the routine lab parameters and correcting the disbalances. And after getting the biopsy report, if it is high-grade serous ovarian carcinoma, then...
Okay, the biopsy shows it is high-grade serous adenocarcinoma. How would you approach Dr. Sushmita?
So I would like to start with the standard 3 cycles of neoadjuvant chemotherapy with taxane platinum, and then reassess after 3 cycles with the response scan and
okay. After 3 cycles, CT scan shows there is a stable disease. There is decrease in CA125, but CT scan still shows there is ascites. What will you do now, Dr. Kripa?
So this is a place like what recently, just now you mentioned, if the response is not so adequate with significant ascites, I would like to, these kind of patients I would like to add bevacizumab. Because like if patient is really young, I can switch over to CAP if she's not affordable. Otherwise, like I'll add bevacizumab to the Paclitaxel regime.
Okay. Dr. Somnath, would you do something different?
Yeah, if patient is not responding, this on therapy, platinum refractory type, if I then can change second line liposomal doxorubicin based along with bevacizumab is not responding with the platinum agent. Otherwise, if patient is responding but suboptimally response, still not surgery interval deviating not possible, as Dr. Kripa mentioned, I'll prefer add bevacizumab along with the platinum.
So,
yeah.
So I would also add on bevacizumab first in this patient and then assess the response.
Okay, Dr. Jaya, what would you do?
I think first want to do a rebiopsy to ascertain the diagnosis that I am correct, because sometimes, about in 5% of these patients, there is a change of diagnosis, and occasionally, this lady was, how old you said, 45. So especially, if this is a young lady and she has ECOG 1 and she still has ascites and walking, talking. So that's what, in our JC we say that, these could be low-grade serous. That is the clinical profile. So in those patients, of course, if it turns out to be low-grade or any other histology, low-grade, of course, will surgeons for surgery, and other histologies will treat accordingly. But of course, it turns out to be high-grade serous. The other panelists have already discussed the role of bevacizumab or changing therapy, but we don't really have a guideline in that area. Sorry, Dr. Rama.
Yes, ma'am. What would you do?
Only one consideration.
No, madam, this is after our JC surgeons have told that we cannot operate, and we've had a big fight that, whether they can undergo a surgery. Yeah. So this is like, if it is an enough, of course, after yeah. So this is every patient after the 3 cycles would go to a multidisciplinary team. And once the surgeons, if they say that they are ready for a trial resection, definitely the patient goes in for a trial resection. That is the first thing that we would consider, and thank you for bringing out that point. And it's only when it is unresectable that we first thing we do is a biopsy, and of course, if it proves high-grade serous, then we go on to second line.
Yeah, so we did the repeat biopsy, and it shows high-grade serous carcinoma. And we started this patient on, since there was a decrease, since there was a decrease in CA125, patient performance status is good, and CT scan showed a stable disease. We continued Paclitaxel and added bevacizumab. After 3 more cycles, patient has responded and taken up for surgery. She underwent R0 resection. What would be the adjuvant treatment now? We'll start with Dr. Jaya this time. Reverse order.
So did we have the genetic report?
So would you ask for a genetic report?
Yeah,
that is the
definitely.
first question.
I think one thing is that, at the time of diagnosis now, before we send them for the first cycle of chemotherapy, at least if there are no other issues, we do try to send them for genetic counseling and testing, or at the time in between, because when they are on chemotherapy, doing a germline testing is at least difficult. So in this patient, did she have a very good response to bevacizumab? Then there is a
dilemma. She responded and she underwent the surgery, and it was R0 resection.
Oh, then that is a difficult. So of course, if she is germline negative, I would probably continue with bevacizumab. If she is germline positive, I would discuss. Although in real life, I've really not had any patient of BEV and PARP together. But if she's had a response to BEV and she's germline BRCA, where we know the benefit of PARP is huge, would probably consider addition of PARP.
What would you do?
It actually depends on whether the germline mutation is positive or not, and if it is positive, then I would maybe ask to convert to a PARP inhibitor. If not, then continue bevacizumab.
Somnath?
Yeah, also is germline is positive, then patient is costed and not an issue. I will put over the PARP inhibitors as a maintenance and off bevacizumab as the solo one data. But if it is germline HRD positive, we can the extract from the Paula one from bevacizumab allowing PARP maintenance. But both are negative, then I think bevacizumab maintenance will be an option.
Kripa, would you give adjuvant chemotherapy to this patient or straight away start on maintenance therapy?
No, residual disease positive, like I'll definitely give 3 more cycles of carboplatin for the patient, and
Okay,
later
if
like I'll consider.
histopathologist shows there is complete response, still would you give adjuvant chemotherapy or you would not give?
Still, I would like to give 2 more cycles at least.
Okay.
I just point.
Yeah.
Actually, this patient is already received 6 cycles of paclitaxel carboplatin.
Even then, that's
Even-
why I asked this question.
Yeah, yeah.
So patient, whatever may be the number of chemotherapy cycle an ovarian cancer patient has received in neoadjuvant setting, the treatment of ovarian cancer has to end at chemotherapy. Adjuvant chemotherapy, you can give 2 cycles single agent carboplatin, that is also beneficial. So treatment has to end at adjuvant chemotherapy.
So, and the maximum number, even in, like, you know, the icon 5 is like about 8, so we
Yeah.
can go up to 8. I mean, that question is debatable if you are using PARP, you know, because if you've already used 6 and then done surgery and there is no residual and she's germline BRCA positive, you know, there is no right answer whether to give 2 more and then continue PARP or whether to just continue PARP maintenance. Because many of these patients do have repeated cytopenias after 6 cycles, and sometimes it's difficult to continue till 8.
So what percentage of patient do you think would likely to be BRCA mutated in clinical practice, Dr. Sushmita?
It should be around 15 to 30%.
Okay, and tumor BRCA mutation, Dr. Shrikant?
It will be around 15.
Tumor BRCA mutation.
Somatic
mutation.
Somatic mutation, excluding BRCA.
Excluding germline
germline
BRCA.
mutation, it will be around 25 to 30%.
It will be around 5 to 7%. So what is the benefit of doing HRD testing? That from the TCGA analysis, we know that around 50% of the patient will have some or other form of HRD. But only issue is that still we don't know what is the ideal test to do HRD and what is the ideal cutoff. And that is why it has not routinely been picked up in the routine practice the way we have picked up the germline or somatic BRCA mutation, because these germline or somatic BRCA mutation has been standardized pretty well all across the globe, but still there is, we have to still reach a consensus for the HRD testing. So as per Athena mono trial, the randomization is 4:1 and it shows that using maintenance rucaparib there is improvement in progression free survival. So would you use in all patients, Dr. Jaya, based on Athena mono data?
No, I think that was already discussed in the previous panel that I would definitely not use in those which are negative, both HRD and germline negative. Definitely consider in those who are germline positive. Who are germline negative and HRD positive, I would consider, but I would also explain to the patient that the magnitude of benefit is less as compared to those who had only germline positive, but definitely would also consider in those patients.
Okay. Any final comments from audience? Dr. Rema, anything you want to add? Sorry, could you please repeat? Could you please use the mic?
Sorry I came late. Was this the case where you had given 6 cycles upfront NACT, but she was germline positive?
So that's what we were discussing, that what are the possibilities if the patient comes out to be germline BRCA mutated, what would be the therapy?
Normally, it's not like that, right? They are platinum sensitive.
Usually they are platinum sensitive.
What percentage of people could come like this?
Those who will not respond to 3 cycles, So we've around 20 to 30% patient will not respond to first line paclitaxel and platinum based therapy.
Who are germline positive?
The germline positive usually respond to, because presence of germline BRCA mutation is a marker that they will respond to chemotherapy. They are usually, they are non-germline BRCA mutated. This 20 to 30%, the value is for all comers, irrespective of their mutation status.
Exactly, that's the reason why is it.
She did not respond to first 3 cycles, that's why we gave 3 more cycles with bevacizumab. Yes, ma'am.
There's one question. When you are combining bevacizumab with that of the olaparib, do you think that the toxicity profile changes of the patient?
Yeah, toxicities are more, definitely, even it is reported higher in the trials. The thrombocytopenia will be higher, and this is what I can think of, thrombocytopenia will be higher, and the tolerance to both bevacizumab and PARP inhibitor will reduce, because the toxicity will add up and the compliance to therapy will also decrease with that.
So, like I haven't used, both the combination in any patient. So we either triage as per HRD whether to use BEV maintenance or PARP maintenance. See, because in that Paula one you didn't have an arm. How much does BEV add to PARP maintenance? That answer we don't know. So, because BEV plus PARP is better than BEV alone, which is understood because she is a BRCA positive. But is BEV plus PARP better than PARP alone? That answer we don't have. So then why combine toxicities of both?
When the benefit is not
When
substantial.
you're looking at Paula 1 trial, how much of the advantage you get into the survival by getting olaparib?
No. So the main thing I'm saying is that it is mainly driven by olaparib. How much does BEV add to olaparib? That is the question. You can get the same advantage by using the single drug. I don't know the answer basically.
So actually we do not know in this how much is the survival advantage by giving, rather adding olaparib to the patients of the HRD positive, those who are receiving already the bevacizumab.
There is an updated analysis from the Paula 1 trial which shows that the overall survival at 5 years is numerically higher with the use of olaparib and bevacizumab compared to, there is no comparison between Solomon here. So the updated data from Paula 1 suggests it is numerically higher, but it has not reached the statistical significance. Because all these trials of maintenance PARP inhibitor, they use the hierarchical testing. That means they did PFS analysis first, and if PFS analysis is statistically significant, then they went on and they did the overall survival analysis. But they have put the very strict boundaries to label overall survival benefit as statistically significant if the p-value is less than 0.001. So these overall survival data is there, but it has not reached the statistical significance even in Solo 1 trial, which has a 7-year follow-up data.
Okay, thanks.
I think if there are no more questions, we will conclude the session. Thank you very much.